welcome everybody who's just joined us. We're going to cover 4 different patients, and these 4 patients are going to cover all the key things about atrial fibrillation that I think you ought to know. And please ask questions as you go along, or we'll save them till the end, but please ask them if you've got anything else you want to know about AF. So let's move on to patient number 1. So I've called this unfortunate 80-year-old lady Mrs. Fractured Neck of Femur because that's what happened. She normally can walk about 200 meters, but she had a fall and broke her hip, and she had surgery yesterday. And imagine you're the medical SHO on call, and you've been asked to come and see her by the orthopedic team, or you might be the ortho Jerry's team. And they want you to see her because she's developed acute shortness of breath, palpitations, and chest tightness. And she's a bit hypertensive, a little bit hypoxic, and I'm sure you're all of you wanting to see her ECG. So this is her ECG. So if you look at this, can you see that it's irregularly irregular? So each RR interval is different from its neighbors, and there's no consistency there at all. They're all different. So this is atrial fibrillation. And the heart rate here is around about 150, give or take. So she's in fast atrial fibrillation. So what's the differential diagnosis here? Why has this lady got this constellation of symptoms? Why is she breathless with palpitations and chest tightness, a bit hypertensive, a bit hypoxic, and in fast AF? Sepsis. Yes, very good. This could be sepsis. It could be a pulmonary embolism. This is a classic bread and butter case. I mean, the cardiology registers get called about these patients all the time. But you know, these are really bread and butter. What could be going on? So sepsis, it could be she's got a chest infection or another form of sepsis. A pulmonary embolism is high risk. It would explain the bit of hypoxia. It would explain her being in fast AF. Very good. Anything else? And are there any other key questions that you want to ask the patient that I haven't told you? Any key questions that I haven't answered in this history? Very good, Emmanuel. Exactly so. Is she known to have atrial fibrillation? Because if this lady's known to have atrial fibrillation and it was rate controlled yesterday, then either they've held off her medications or something has gone wrong that's totally unrelated to the atrial fibrillation to make her tachycardic. If the atrial fibrillation is new, then that explains why she's tachycardic. It could easily be simply the stress of the surgery has caused the atrial fibrillation, but we should consider the other obvious potential causes, of which I've just listed a few. But is the atrial fibrillation new or old? And you also need to think about anticoagulation here. So the treatment here, you want to treat the underlying cause. Very much the important thing here is not to just think atrial fibrillation, treat the atrial fibrillation. If she's got severe heart failure causing the atrial fibrillation, then it could be that driving the tachycardia. A rate of 150 in an acute situation isn't really enough to be causing compromise due to the tachycardia. So look for other causes. But a beta blocker could be used to slow her down. And we'd need to think about anticoagulation in discussion with the orthopedic surgeons. How do we decide about anticoagulation? I'm sure you're all familiar with the CHADS-VASc risk score. There are loads of different ways of doing it. I quite like MD Calc for calculating this. If I don't hope need it for CHADS-VASc, but for some of the other markers I do. So the CHADS-VASc is great for measuring risk of stroke and deciding about anticoagulation. It gives you the impression that all the markers are made equal apart from stroke and age. And reality is that being a woman, puts you at slightly more risk than a man, but is not nearly as high a risk as being diabetic. So there is a little bit of nuance to this, that if you score 2 or more, you need anticoagulation. But if you're a man and you're diabetic, maybe you need anticoagulation. So it's not quite as clear cut as this, but this is a really good way of working out who needs anticoagulation. Now, we used to use Hasbled score, and the very latest NICE guidance moves us towards Orbit as a bleeding risk score. Don't worry too much if you're familiar with Hasbled. You won't go too far wrong with the Hasbled score, which I do tend to have to use a calculator to remember. But Orbit score is simpler. If you look at the detail of this and why they've changed over, the C index is a measure of how good a marker of bleeding risk is. And if it was perfect, it would score 1. If it was as good as tossing a coin, it would be 50-50, so it would score 0.5. You can see that the Orbit score scores 0.67, which makes it fairly poor, but it's slightly better than Hasbled at 0.64. Not a lot of difference to cause a lot of extra learning for a lot of doctors switching over from Orbit to from Hasbled to Orbit, but there you go. So the latest that we're using is this Orbit score. Now, if you're not sure if they should be anticoagulated, one way of doing it is to calculate the CHA2DS2-VASc score and subtract from it the Orbit or Hasbled score. And if you're still positive, then you should be thinking about anticoagulation. So positive, or if you score 0, you should probably be still thinking about anticoagulation. But this helps with the discussions and consideration, because it's a decision that you make between you and the patient, and there are risks versus the benefits. Something which often comes up is falls. If a patient is at risk of falls, should they be denied anticoagulation? It's a challenge because a lot of patients at risk of falls have got lots of other comorbidities and maybe at more risk of having a stroke because of those comorbidities. So this trial looked at patients being sent home on anticoagulation, and the doctors sending them home judged them to be at high or low risk of falls. Now, bear in mind that they would have only been recruited to this observational study if the doctor seeing them felt that it was appropriate to put them on anticoagulation. So the patient that's falling over every 5 minutes and banging their head on the floor probably wasn't anticoagulated and therefore wouldn't be represented by this study. But what it does tell you is that if you feel that it's not excessively high risk to start the patient on anticoagulation in view of the falling, then even if they are at relatively high risk of falls, they don't do any worse than patients at low risk of falls in terms of risk of major bleeding. And there's other data as well that, you really do need to be falling frequently or falling and hitting your head in order for us to be recommending not to anticoagulate the patient. Great, so that's patient 1 done. Thank you. Patient 2. So this lady is Mrs. Atrial Fibrillation, and she's 55 years old. She's been referred by her GP, or you could imagine if you want that you're sitting in your general practice wondering whether or not you should be referring this patient. And she's been referred with recent onset of atrial fibrillation. Now, what questions would you be asking her to get a feel for her symptoms of atrial fibrillation? So tell me what symptoms you would be looking for with atrial fibrillation in the first instance. Yeah, palpitations. So palpitations can be very troublesome just because the patient is really worried that their heart's going to stop every time it palpitates. And often in atrial fibrillation, that means that the heart goes really fast because they get a surge of adrenaline, and so their heart races. And simply reassuring them that their heart is not going to stop in atrial fibrillation can help enormously with symptoms. Dyspnea is another very common one. So we're looking for exertional breathlessness caused by the atrial fibrillation. Pain, not so much. I wouldn't expect atrial fibrillation to cause pain. I mean, there are instances where it might, if you had angina and your heart's working less efficiently, it might lower the threshold for you getting angina, but it won't cause pain itself unless you're in fast atrial fibrillation, and then it's a bit like doing an exercise test with coronary artery disease. But yes, worth certainly asking the patient. Dizziness and syncope. So they can feel dizzy with the atrial fibrillation, but it's very rare to get syncope with atrial fibrillation. Sometimes when you go from atrial fibrillation back to sinus rhythm, you can have a moment or two where the sinus node has been asleep and doing nothing during the AF, and it has to wake up and start working. So when you transition, when you cardiovert spontaneously from atrial fibrillation to sinus rhythm, you can have a termination pause, and that can cause syncope. But atrial fibrillation, even very fast AF, doesn't cause syncope itself. It's the going back into sinus rhythm and having a pause that does it. Fatigue, absolutely. So that would be the other big thing that patients complain of. And ask about it being episodic and how long the episodes last. Sometimes patients complain that they feel terrible for a morning and then they feel fine in the afternoon. And that's often something that makes me think maybe they're having episodes of atrial fibrillation. They feel rubbish during the atrial fibrillation and better in between times. Great. Now, having assessed the symptoms and found out that this lady has got substantial symptoms because of the atrial fibrillation, what are the other key questions that you want to know about the patient? So, sure, Chad's VASC, you want to know about anticoagulation, you want to know about bleeding risk, so let's go that as a given. But what other key factors beyond the symptoms of atrial fibrillation do you want to know about? So thank you for suggesting the duration of the atrial fibrillation. I'll talk about that a bit later on in this presentation. That's not what I'm going for here. The patient is a bit of a hint. Yeah, alcohol consumption, excellent. Alcohol is a big thing in atrial fibrillation. So really important to know about that. It's a very common trigger, very common reason that people keep on with atrial fibrillation. So that's a big factor. Any others? So she's thyroid, yes. Over or underactive thyroid certainly will potentially cause atrial fibrillation. We certainly should check thyroid function in all patients with AF. So her obesity is a big factor, and the more obese patients are, the more likelihood that we're going to struggle to control the atrial fibrillation. And then alcohol, and we've already said about risk factors for bleeding and stroke. So lifestyle is really important with patients with atrial fibrillation. And this, if you imagine, is her ECG, which shows atrial fibrillation with good rate control. So it's not particularly rate control that is causing this lady's symptoms. It's the fact that she's in the atrial fibrillation. And there's a real spectrum between patients who are blissfully unaware of being in AF, even if that AF is making their heart go fast at a rate of 150 odd, and patients who are terribly symptomatic, even from rate-controlled atrial fibrillation. And it's actually the patients with fast atrial fibrillation that's asymptomatic that tend to develop a tachycardia cardiomyopathy. So the heart gets running a marathon constantly for months potentially, and they end up presenting with heart failure caused by the atrial fibrillation. These patients tend to present very promptly when they get AF, and it's because of the symptoms caused by it. And how do we manage the atrial fibrillation? Well, this is, I suppose, the key slide in this whole talk, because this is my very straightforward demystification of atrial fibrillation. How do you manage it? Well, there are 5 things. The first is the most important. It is the anticoagulation, because that's the thing that's going to make the patient live longer. It's if they have a stroke, that will devastate their quality of life. So think about Chad's VASC in orbit or has bled, and think about anticoagulation. Really critical. And the nice guidance is to use a DOAG these days. So really important to anticoagulate. Point 2, rate control. And we're aiming probably for a heart rate below about 90. Actually, the evidence for that is fairly poor, and probably more lax rate control is okay, but I feel a bit queasy about faster rates. Sometimes patients feel worse for going slower, and so I might accept looser rate control than this, but I certainly have a little bit of a try to get their rate down to below 90. No lower than that unless they feel better at lower rates than that. And a beta blocker is the first line drug for that. Something like bisoprolol, not sotalol, not as a first line. That would be rhythm control, and it's not a bad option, but we start off thinking about rate control. And failing that, if they've got asthma or intolerant to beta blockers, then diltiazem or maybe verapamil are good alternatives. So rate control, and then think about doing an echocardiogram. Now, NICE guidance actually doesn't say do an echocardiogram. It says consider it if you think it's going to be pertinent to their management. And the question is, why have they gone into atrial fibrillation? Do they have a valve problem that you've not heard because you've not got great ears, or just because it's hard to hear a valve problem? Maybe they've got an ASD that you won't hear that murmur. You won't, I think, hear the flow murmur it causes across the pulmonary valve, and yet it could be causing right heart dilatation and atrial fibrillation. So I think it's very hard not to do an echocardiogram in somebody with atrial fibrillation in order to check why they've developed the AF. You might say it's heavy alcohol, it's holiday heart syndrome, it's they've binge drunk alcohol and that's caused them to go into AF. But why did it cause that patient to go into AF and not all the other people that binge drink alcohol on holiday? And alcohol's a potential cause of cardiomyopathy. So I always do think an echocardiogram needs to be carefully considered. Point 4 is to look at it holistically. Atrial fibrillation is the diagnosis, but I don't tend to think of it quite as a diagnosis. I know it is, but it's the whole patient that is the problem, and the atrial fibrillation is almost a sign of what's actually going on with the patient. This lady's developed the atrial fibrillation because of a heavy alcohol intake, because she's overweight, because she doesn't exercise, because she's hypertensive. I could say exactly the same for a man. I just thought I'd put a woman in here because the stereotype is a man. Um, it's such a common constellation of features. Often they have obstructive sleep apnea, which helps to drive the atrial fibrillation. And if we're serious about getting her out of atrial fibrillation, or we're serious about her being healthy in the future, then all of these things need to be addressed. So it needs a really good holistic approach to managing a patient. And then point 5. If the patient has ongoing symptoms or if they're biologically young, then refer them on to a specialist. And we see loads of patients with atrial fibrillation, and generally speaking, we just do this points 1 to 5. But there are certainly some patients who we should be thinking about controlling their heart rhythm, so getting them back into sinus rhythm, rather than just controlling the rate and anticoagulating them. And we're doing that for symptoms. We are not doing it to make them live longer. There have been countless studies trying to show that it makes patients live longer and do better if you get them back into sinus rhythm, and none of them has convincingly shown that. So all those attempts, any one of those could have been positive, but they were all negative. So but if they're biologically young, then we certainly need to reconsider that. And if they have ongoing symptoms, some of these people have terrible symptoms. So we should certainly be seeing those to see what we can do for them. And there are various things we can do. There's a paper in the latest European Heart conference, the European Society of Cardiology, which shows about a 70% reduction in mortality by doing a pace and ablate approach for patients with atrial fibrillation for certain groups of patients. So there are all sorts of things we can do, but the classic thing we do is an AF ablation, and this is a really complex and difficult procedure, which we do extremely well here, but there are risks attached to this procedure, and it's not something to undertake lightly, and it's not something to think about undertaking in a patient like this example without a really holistic package of care. And this information I'm giving you, it comes from the latest NICE guidelines. They came out in April. These are pretty good guidelines. They're quite a good summary of atrial fibrillation, and it explains the thinking about the evidence. So please go to those and have a think about it. And in that, it's clear what I've just said, that you're referring for specialized management promptly if the patient has ongoing symptoms. So be confident and comfortable following steps 1 to 5 with your patient. And if your patient's 50 and in very good health, and even if they don't have symptoms, then we probably do want to see them. I've been asked the question, is there any reason I haven't named Verapamil? I would be happy for you to use Verapamil. The caveat is if you've got heart failure, Verapamil is a very bad drug. Diltiazem is not a good drug if you have heart failure, but Verapamil is more negatively inotropic and worse. So, and it's one I think people are not so familiar with. So Verapamil is a good rate control drug if you use it, if you want to, and you can't use a beta blocker. Diltiazem would be my first choice if I wasn't using a beta blocker. There are not many papers that you should be aware of, but I would suggest Affirm from 2002 as a seminal trial showing that patients with rate control did just as well as patients with rhythm control. In fact, they probably did slightly better, but that was probably because they were stopping anticoagulation in patients who were rhythm controlled, and they were then having strokes. So there's data going back years that show us the benefits of it. Another couple of quick papers. This is a beautiful study of alcohol. So I kind of think I wish I'd done when I was in research, because it's so simple and it's a New England Journal publication. So this looked at 140 patients, and it looked at half of them in an abstinence group and half of them who carried on drinking. And they were drinking about 10 or more standard drinks a week, this is Australian paper. That correlates with around 14 units a week. So it's about the same as us. And the difference, so these were drinking just that or more. So these weren't heavy drinkers, but they were drinking certainly as much as we would recommend. And you can see that there was a 20% absolute reduction in recurrence of atrial fibrillation if patients stopped drinking versus carried on drinking. If we compare that with Cabana, which was a massive, really hotly anticipated trial done to try and show a mortality benefit from doing AF ablation, that showed a 20% absolute reduction in AF recurrence with doing an AF ablation. So the same reduction in risk is achieved by stopping modest drinking versus having a major procedure which carries a risk of, we would quote, about 1 in 500 of death. So it's really important to address the other risk factors. Losing weight would have similar benefits, and good blood pressure control and exercise are other really important things. Great, moving on to patient number 3. So patient number 3 is Mr. Exercise. He's a 52-year-old gentleman, and he cycles about 200 miles a week. Now, we do see patients who exercise themselves into atrial fibrillation, and it tends to be cyclists. They seem to really put their body at the peak sort of limits of performance and sustain that for a long period of time, and it's that puts them into AF. Interestingly, racehorses get AF as well. But just think of this as a fit, healthy 52-year-old, and this patient is suddenly getting fast onset palpitations, and they can occur anytime, but they do also occur during exercise. They usually last for about 1 hour, and then they spontaneously clear up. And he feels dreadful during the episodes. And for our cyclists, they feel terrible because they're 52 and they're beating all the 30-year-olds at cycling, and then suddenly they can't because they go into fast atrial fibrillation, and that's really frustrating for them. This gentleman doesn't have any other risk factors. He's a fit and healthy patient. So imagine our 50-year-old doesn't have to exercise a huge amount, but a fit person who doesn't have lots of risk factors, who goes into fast atrial fibrillation. Now, the occurring during exercise is a red flag for serious arrhythmia. So that should immediately raise eyebrows. It could be AF, but we can't assume that. And this does make you worry about VT. So that should certainly raise eyebrows. But in this instance, it does turn out to look a bit like this. So this ECG shows atrial fibrillation again, but I'm sure you're immediately looking and saying, goodness me, isn't this going fast? And this is going at a rate of about 180, maybe slightly more. Young patients who have fit and healthy AV nodes tend to conduct the atrial fibrillation fast because he'll put his heart rate up to 180 during exercise. There's no reason he can't do that when in atrial fibrillation, whereas more elderly patients tend to have rate-controlled atrial fibrillation. Rate-controlled atrial fibrillation, not on any drugs, probably tells you there's something not good about that AV node. That AV node isn't very healthy, and those patients often end up needing pacemakers, although that isn't an indication in itself for pacing. So, what are our treatment options for this gentleman when he pitches up in A&E or in your GP surgery and he's terribly symptomatic? He's been getting these palpitations for a while, he's been ignoring them, but now it's happened and it's been continuous and it's just kept on going the last 5 hours until he's been able to see you as an emergency. What are you going to do to this gentleman? Yeah, we'll consider a cardioversion. And somebody else is suggesting rate control only. Well, that's just fantastic. I love it when people disagree. So who wants to do a cardioversion and who wants to consider rate control only? Does anybody else want to weigh in here? Or lots of people going for the cardioversion option. If it's new cardiovert, if it's been going for a while, then no. Are we sure he hasn't had asymptomatic AF? So the thing here is he probably has quite a slow rhythm in sinus rhythm because he's very fit and he goes really fast in AF. So if we rate control him in AF, he's going to have a pulse rate of 30 in sinus rhythm, and that's going to make him feel terrible. So rate control here is probably not going to work. It's very clearly defined episodes that we're getting. So we can be pretty confident that this has been going less than 48 hours, which is our key metric for do we need to spend a month anticoagulating the patient before doing a cardioversion. The alternative is to do a transesophageal echocardiogram, make sure the atrial appendage is clear of thrombus, and then cardiovert. So we can avoid the month wait, but it's a real hassle to do a TOE for that purpose. So this is less than 48 hours. We can therefore cardiovert. If we want to rate control while we're planning a cardioversion, we can try it, but he probably will struggle with that because of how fast he's going. So a cardioversion is going to be the first choice option here. And when we say without anticoagulating, that doesn't mean that we don't anticoagulate afterwards if his CHA2DS2-VASc score would justify it, but it simply means we don't have to anticoagulate beforehand. And in this gentleman, he's not got any risk factors. He's only 52, so we don't need to anticoagulate him, full stop. Bear in mind that the vast majority of patients cardiovert anyway. So if you can rate control him and just leave him alone, he'll probably cardiovert. But if he's not had anything to eat in the last 4 hours, we can just sedate and cardiovert him and get him home. It's quicker and more convenient for him. So that would be a good option here. Now, imagine that he has recurrent admissions, and those are symptomatic admissions with fast atrial fibrillation. A good option for trying to keep him out of atrial fibrillation or even to try and cardiovert him at home is to give him flecainide. Flecainide should be given with a little bit of bisoprolol unless it's purely being used infrequently as a pill in a pocket. And it can only be given with normal hearts because if you've got a cardiomyopathy, it can put you into VT-VF. But flecainide in somebody like this can work quite well. He can keep hold of the tablets and either he can take them regularly to keep him out of AF, or he can just, when he has an episode, take the tablet to cardiovert himself. But despite attempting that, he's still having fast atrial fibrillation. So he now becomes a very good candidate for an AF ablation. So this kind of patient really benefits because he's getting frequent hospital admissions with very symptomatic AF, and atrial fibrillation ablation has got a high likelihood of working. It will make a big difference to his quality of life. This is the kind of person we want certainly to be seeing. Great. Patient number 4. So patient number 4 is Mr. Easy Rider, and he has had multiple admissions with palpitations. And these are sudden onset. They last until he attends hospital for cardioversion. And this is his ECG during an episode. So please Ashley, ask the question as we go along. But so while Ashley's typing the question, everybody else have a look at this ECG and tell me what this ECG shows.
Sorry, I might ask it because it's easier to ask than
Oh,
typing.
go ahead. Yeah.
With the previous person, the 48-hour window, does that... He came in 5 hours of it being consistent, but given that he's been having episodic episodes in the past, does that count towards the 48 hours or does it not?
No, it doesn't. It doesn't. It's a good question. I mean, let's say for the sake of argument, he's having it about once a month. But even if he was having it once a day, it's within 48 hours. So technically, he doesn't need anticoagulating. There is some evidence that the atrial appendage doesn't work properly for days after having a cardioversion, which is why patients need to be anticoagulated after cardioversion, even if they don't have appendage thrombus beforehand. But within 48 hours, it's continuous episodes. If he had an episode 47 hours followed by 48 hours, he'd still technically not need anticoagulation, but that's the kind of patient I'd be starting to sort of say, look, benefit of the doubt, low risk from anticoagulation. Great. So we're looking at this ECG. So we're suggesting Wolff Parkinson White with atrial fibrillation. So I will at some point during your time with us show you a pre-excited atrial fibrillation because it's a key thing to spot, but that is not this day, I'm afraid. AF with strain. So you're suggesting that there's maybe some left ventricular hypertrophy and a bit of ST depression here. Yeah, I wouldn't particularly say that that it looks like a strain pattern. So the rate here is about 150 beats per minute. There are some beats which are slightly longer than that. This is about a 2, this is about a 3, relatively. But for the vast majority of it, it's pretty regular and rate of about 150. Does that give you a clue? So this is atrial flutter. Can you see the flutter wave here? Our sawtooth flutter wave. And we've got 2-to-1 conduction here. And over here, we've got 3-to-1 conduction. So atrial flutter, and there's a little bit of variable block, but the characteristic thing is the flutter goes at a rate of 300. Your AV node doesn't like conducting at a rate of 300 unless you've just been given flecainide. So it doesn't go that fast, but it can go very happily to a rate of 150. So this is an atrial flutter ECG. And if you control the rate, you can see the flutter wave much more clearly, or you could give some adenosine if you're in doubt, and that would reveal the flutter wave much, much more clearly. So atrial flutter. Now, I could tell you all sorts of other things about this patient, but the real point of having him in this presentation is to tell you about atrial flutter, because it sounds very, very similar to atrial fibrillation, but it isn't. But it is in other ways. So normally you have your sinus node sending a signal through your atria to the AV node, which then conducts rapidly down and round the ventricles to make the heart contract in a coordinated way. In atrial fibrillation, rather than that coordinated signal from the AV node, you get a swirling chaos of electrical activity going through the atrium. And as that swirls around, it'll keep on shouting at the AV node to go. And if you've got a young, healthy, good hearing AV node, it goes really fast. If you've got an elderly, deaf AV node, it can go slowly. But it will never go regularly because this chaos doesn't follow a specific pattern. It goes all over the place. Atrial flutter, on the other hand, is a very organized rhythm. So instead of this chaos, you get a circuit going round and round and round the atrium. And it goes round the atrium at a rate of about 300 beats per minute. And as we've said, that leads to your 2-to-1 block, your heart rate of 150. Now, as it goes round the atrium, there is a slow zone where it goes between the inferior vena cava and the tricuspid valve. And we call that the cavo-tricuspid isthmus. And if we ablate a line across this narrow slow point, then this circuit can no longer be, because we've broken the electrical wire that is this circuit, and we have cured the atrial flutter. So curing atrial flutter is actually relatively easy because we can get to the right atrium easily. To get to the left atrium where the pulmonary veins are that we have to ablate in AF, we've got to put a needle and get across between chambers, which is very doable, but it does increase the risk. And we have to burn near the throat, which is partly why the risks of mortality come in, and all the complexity and the time it takes to do that versus just burning a little line in the right atrium, which is far away from things that you're going to damage. So much lower risk, very much quicker. And for that reason, atrial flutter, we should always be thinking about an ablation. Maybe not first episode, but certainly in any symptomatic patient, we need to be thinking about atrial flutter. Now, there are other atrial rhythms beside that I won't overcomplicate things with, but these are the two ones that you need to know about. And the atrial flutter, think, because it's a very organized circuit. It can be difficult to rate control because if you've got a really organized wave going round, so you've got a loud shout going to the AV node 300 times a minute, it's going to ignore half of those because it's just too fast, but it will hear the other half. And if you deafen it to hearing that rate of 150, then you're not far off of sometimes causing complete heart block. So rate control can be really difficult in atrial flutter, but we use the same treatments to try and achieve it. Both need anticoagulating in exactly the same way. Both can be electrically cardioverted in the same way. You often need less joules for atrial flutter, but don't worry about that. But the big difference is that we can cure atrial flutter, whereas AF ablation, it can be really valuable, can be really important. We do lots of it here, but it is higher risk, it is complex, and it doesn't last forever. So really important difference. Now, I said there were 4 customers, but I lied. We have Mr. Easy Rider's identical twin, who is completely asymptomatic. But he wants to be safe. He's got a lot to live for. He's living the good life. He's married to his brother's identical twin sister. And so he gets himself one of the many, many possible options to monitor his heart. And this option that he has to monitor his heart does an ECG for him and tells him that he needs to see his GP. So imagine you're in your GP surgery and you happen upon this customer who wants to know what to do about this. What do you think? So this is an increasingly common scenario. It hasn't actually happened to me yet in clinic, but I am expecting it to any day now. Complete silence. It is atrial fibrillation. So what do we do about atrial fibrillation that's been detected by this gentleman's personal monitor? You could say, is it medically designed to detect it? But it's got a strip here that can really only be atrial fibrillation. So we can look at that and say we can diagnose AF. How long is the run? Well, that's a good question. This is a short strip of about 10 seconds. He doesn't know. Does it matter how long the run was? Follow my 5 steps. Very good, very good. So this is a really challenging situation. Um, it's been addressed recently by the Loop study, which reported just last month, and was one of the highlights of ESC. And this study took 6,000 patients, and they implanted in a quarter of them a loop recorder. So this is a real gold standard way of detecting atrial fibrillation. And if you had more than 6 minutes of atrial fibrillation, anticoagulated the patients. And there was a very high take up of the anticoagulation in the patients that were recruited. They deliberately really enriched their cohort to have a high CHADS-VASc score. So the CHADS-VASc score was 4. Very, very high CHADS-VASc score for a study. If you look at the AF studies of anticoagulation, actually they had lower CHADS-VASc scores on average in all of the patients. So high risk cohort with vascular disease. And this is just sort of cohort you would have thought that it would be a very clear benefit to anticoagulation. But if we look at the results, there is a reduction in risk of stroke or arterial embolism, but not one that reaches significance. And there is an increased risk of bleeding. Again, doesn't quite reach significance. I'm not showing you that on this slide. But the all-cause mortality is no different whatsoever. Now, I don't want to have a stroke and remain alive, but you've studied 6,000 patients or 1,500 patients with a loop recorder with an intervention. You've identified atrial fibrillation in a large number of them. Where's the number for? It wasn't an infrequent. I think it was as much as a third of the patients developed atrial fibrillation lasting 6 minutes and ended up on anticoagulation. So it's a frequent intervention, and you're not showing any improvement in mortality, and you're not showing a significant reduction in risk of stroke. So how many patients would we have to study to benefit one patient in this? Maybe this is patients are too high a vascular risk, because obviously not all stroke is thromboembolic. Patients who are arteriopaths are at risk of having strokes that anticoagulation won't protect you against. Maybe it was too high a risk cohort. 6 minutes of AF, maybe that was too short a period of atrial fibrillation. Maybe we should have to have an hour of it, but we don't honestly know the answer. So this sort of patient who comes along with a short run of atrial fibrillation, we really don't quite know what to do with that, and we need to have a careful discussion about it. But it's very different to screen for atrial fibrillation and find it than it is to find it on a 12-lead ECG or have the patient present with symptoms of it. So jury's still out on this one, but I would be thinking about doing a 48-hour or maybe a 7-day cardiac monitor to look to see how long the durations of atrial fibrillation are, to try and think a little bit about the risk, although that might not help me much. If it tells me the patient's in AF for a day, that helps me a lot. But what that 7 days tells us compared to a year, who knows? Might have a good 7-day stretch. And I'd very carefully discuss with him the risks versus the benefits. Wonderful. So that's my whistle-stop tour of atrial fibrillation. I hope I've covered all the things that you might ask about atrial fibrillation. This is my summary slide of my 5-point guide to how to manage atrial fibrillation. Please ask any questions, and next week we will talk about blackouts. Thank you very much for listening. Are there any questions?